Welcome to another episode of What Brings You In Today. I'm Erica Bennett, and I'd like to start out by thanking all of our listeners for tuning in. Make sure to like and subscribe if you haven't already. And then, of course, if there are any topics that you are interested in hearing more about, please let us know in the comments so that we can bring on a guest to address those. But today we are here with Dr. Yadav, and he is a pulmonologist at SGMC Health. So, Dr. Yadav, what brings you in today?
I'm here to talk a bit about lung cancer screening, about the new tools that we have available at South Georgia Medical Center to help diagnose lung cancer effectively and at an earlier stage to help our patients and the community, and to talk a bit about the risk factors and lifestyle changes we can do to reduce the incidence of lung cancer in the community.
Perfect. All right, lungs, everybody's got them. I don't think we really think about them until we're maybe running or walking, get out of breath, right? So we can start, before we hit on lung cancer and, lung health, let's talk about your background a little bit.
I'm a dual-trained pulmonologist and critical care medicine physician. Pulmonology is like respiratory medicine, and critical care medicine is the intensive care medicine.
Okay.
So I take care of patients in the outpatient and inpatient settings. In the outpatient, I practice as a respiratory care physician, as a pulmonologist, where I deal with problems like COPD, asthma, diagnostic aspects of lung cancer, and various other pulmonary conditions like interstitial lung disease, pulmonary hypertension, and so on.
Okay.
I also take care of patients in the ICU and patients who are on ventilator, who are critically ill, having multiple medical problems, organ failure, respiratory failure. So
that's a pretty variety of patients you've got there. You've got your pulmonology side, but the critical care unit, it's a whole nother ballgame. How did you decide is that normal for a pulmonologist to dual specialize in critical care, or how did you decide to do that?
That's an interesting question. Actually, in the United States, this is a unique combination. And majority of the pulmonologists that are training now, I would say at least 80 to 90%, they have dual training.
Okay.
Because the programs are pulmonology and critical care medicine combined fellowships. So it's a 3-year integrated program where you get training in intensive care medicine as well as pulmonary medicine.
In regards to like hospital population of patients, do a large majority of patients who are hospitalized, the pulmonary issues? Is that normal to have both of those? Is that why that kind of tends to lead that way?
I would say when patients are in the intensive care unit, majority of them need some kind of support in terms of breathing. And a large number of them are on ventilators. So it just makes sense that patients who are on ventilators, pulmonologists take care of them because we have training in bronchoscopies, management of ventilator, lung physiology, and I think that is where it came from.
And what interested you in the lungs? So what made you decide to pursue pulmonology?
Essentially, my background is from India as a trauma surgeon, and then I've always seen how injuries can make people sick and can lead to multiple organ failures, and how this can derange the physiology of human body. And essentially, the diagnostic dilemma and the acuity of medicine at that time, when people are dealing with so many serious life-threatening conditions, the ability to diagnose, support, and make them better, I think it's very rewarding.
Yeah.
At the same time, lung itself, pulmonology, is a very cerebral field. A lot of conditions in the body can manifest in the lung. Like patients, I've seen rheumatoid arthritis getting diagnosed based on patient presenting with respiratory complaints. A lot of interstitial tissue disorders, they can manifest as lung disorders, like cough, wheezing, shortness of breath. You would not think that patient has a systemic disease. It's only when you do the workup you come to know that the patient is suffering from a systemic disease, which is a connective tissue disorder, but it manifested in the lung first.
Okay.
So I just think that this is a very interesting and a very rewarding combination. You get to practice inpatient. You take care of the sickest people in the most difficult times. And you also have a nice variation where you can do office practice.
Yeah.
And in addition to that, you have tools like robotic bronchs, endobronchial ultrasound. So there is a procedural aspect also to it. So I think it gives you a whole spectrum to practice.
Yes.
I think it's a unique combination.
Yeah. All right. Well, let's talk about. You mentioned cough, wheezing, asthma. What kind of symptoms, and maybe I just listed them, would someone have where they might need to consider seeking medical advice? And is that typically start with your primary care provider? But when should someone be concerned?
In terms of symptoms, any unexplained weight loss, any unexplained cough which lasts more than 4 to 6 weeks, any blood coming in the phlegm, any loss of appetite, any lumps or swelling that you find unusual and you observe in your body. All these symptoms, they should not be ignored. And medical help should be sought early.
Do you think people ignore them longer than they should typically
They do,
around here?
unfortunately. Unfortunately, they do. And a big thing now is preventive care. The USPTF, United States Preventive Task Force, it gives you the guidelines, what kind of preventive screening you have to do to detect diseases earlier.
Yeah.
And lung cancer is one of them. So a lung cancer screening program is a nationwide recommendation by USPTF, and it says that anybody who is in the age group of 50 to 80 years have smoked for more than 20 pack years and are currently smoking, or they have quit within the last 15 years, they qualify for an annual low dose CT scan of the chest.
And what does that look like? What does that procedure look like? You go, what kind? Walk me through it.
It's a non-invasive procedure. It's just like I would say just like a bigger form of X-ray.
Okay.
You just have to lie down on the table, and then the CT scan machine, CT scanner, it just scans your chest. You lay still for a few minutes, and it takes a picture of your lungs.
Okay.
And if they detect any nodules, any spots that look suspicious, or that may warrant any invasive diagnostic workup, the physician can pick it up at an early stage.
Okay.
The idea is to detect lung cancer at the earliest possible stage, because the treatment and the outcomes are entirely different. To give you an idea, if somebody is detected with lung cancer at stage 1, the 5-year survival you're looking at is 60 to 70%.
Okay.
On the other hand, if it is stage 4 lung cancer, the survival 5-year is just 10 to 12%. So this kind of, this is the...
So it's huge to catch it early.
Correct. It's a big deal, actually.
And tell us about, I know a lot of people probably avoid getting screened because they don't want to know. They don't want to know that it's there, because then what happens after that? Like all the things, if it is there, what they have to do. So tell us a little bit about that. I can't even say it.
The bronchoscopy?
Yes, bronchoscopy.
Okay, once we see these nodules on the CT scan, essentially there are different ways of going after them to find out what they are. Essentially, we need a tissue sample, right? To find out whether they're cancer or they're infection or they're something else. We can do it in a different number of ways. One is bronchoscopy, and I'll talk a bit more about it. The other way is to do a CT-guided biopsy, where a needle is pushed inside the lung after giving a local anesthesia under guidance of CT scanner. And the third thing is obviously surgical sampling, where the chest is opened and there's a biopsy, actual biopsy done by the surgeon. Everything comes with its own pros and cons, right? And unfortunately, all the procedures come with side effects. And the whole idea is to minimize the harm and the side effects by utilizing minimally invasive technique. That is where we utilize the robotic bronchoscopy. because ion robotic bronchoscopy, which we have at South Georgia Medical Center, it's a cutting edge technology. It is the latest innovation in technology, which has been a game changer. What we do in that is we pass a very thin, flexible, maneuverable tube through the airway. It has a tip which has a camera. So you can look where you're going and navigate it or steer it through all the smallest airways and get access to the most peripheral part of the lung, which is not possible with the traditional bronchoscope because they were thick. And human airway has 23 branches, 23 generations of human airway. Starts from the trachea, and then it branches and then branches. So there are 23 divisions. With the traditional bronchoscope, you can hardly get to the fourth or the fifth generation. With ion bronchoscope, because it is so thin and it is more maneuverable, it is more flexible, you can navigate up till 10th or 12th generation of airway.
Wow. So you're able to get deeper in the lung?
Correct.
Okay.
Deeper and into more difficult to reach areas.
Okay.
You can actually access all the 18 segments of the lung. And not only that, actually, maneuverability, dexterity. When we use a traditional bronchoscope, the pulmonologist is holding the bronchoscope with one hand, and they only have one hand to utilize the sampling needle or the forceps. In robotic bronchoscopy, we have a robotic arm that does the job, and you have a console and a tracker. You can just maneuver it and advance the tube. Once you have located the spot with pinpoint precision, you lock the tube there, and you have both the hands free to do whatever you want to do.
Yeah. Was it hard for you to learn maneuvering the robot?
I think it's easier for the kids. And
Yeah. I've drove the regular Da Vinci that we have, and it is interesting. The kids, they can do it real easy. But it is cool how you can get that like 360 rotation and stuff that you cannot do with your hands alone. So, well, that's phenomenal. I mean, that's huge to be able to get there earlier and decide what it is earlier. I mean, in the past, did people just have to wait until it got... how did that, or did you not even detect it until it got
I would say detection was there, but first of all, the lung cancer screening program was not as widely implemented. Now that it has been implemented, we are picking up lung cancer at a much earlier stage.
Okay.
Now, coming to your second question, how would you diagnose if you did not have a robotic bronchoscopy? If they were very tiny spots, you would just get repeated CT scans.
Okay.
Just to watch them, whether they're growing or they're not growing. Some of the cancers can be slow growing.
Yeah.
Or you would go for the CT-guided biopsy. Now, the problem with CT-guided biopsy, there's a very high chance of developing a pneumothorax, which is like a puncture of the lung and air getting trapped inside the chest. Up to 10 to 20% of people can get that pneumothorax.
Okay.
With robotic bronchoscopy, the chance of developing a pneumothorax is less than 4 or 5%.
Okay.
So there's a huge difference in the incidence of side effects.
How does that make you feel, being able to have these tools now that you can kind of diagnose earlier and treat earlier, just as a physician?
I mean, I feel immensely grateful to this technology. It is helping the people and it is helping our patients. You feel more confident that you can go after smaller nodules which are located in difficult parts of the lung. Lung has a complex anatomy. But with these tools, we can actually access the most complex anatomy of the lung. As I said, you can get nodules in all the 18 segments. And in the peripheral 1/3 of the lung, which is far away from the trachea, where you start the bronchoscopy. So this was something which was unimaginable, I would say, 5-10 years ago.
Yeah.
So it has definitely empowered us. It has definitely given us more flexibility, more options. And it is being reflected. The outcomes of lung cancer are improving. And a large part of it is because we are able to diagnose lung cancer at an earlier stage nationwide. And at South Georgia Medical Center, I'm glad we have implemented this technology now almost for 1 year.
Yeah.
And we have had some excellent results. We have detected cancers in, say, 1 centimeter nodule, 1.2 centimeter nodule,
Wow.
which is what, like 10
Yeah.
ml, like this tiny in a lung. So
Yeah.
this is a huge accomplishment, and I'm glad we are able to offer this technology to the community.
Yeah, absolutely. Let's talk a little bit about prevention for lung cancer and in general and how we can keep our lungs healthy. What's the best thing we can do to keep our lungs in check?
Yeah, since we're talking about lung cancer primarily here, the biggest thing here is to stop smoking. 90% of the cases of lung cancer are in some way caused by smoking.
Yeah.
Now, smoking can be, the person can be smoking themselves, or there is a spouse or parent or
Secondhand
somebody
smoke.
who's secondhand smoke. Both of them are equally dangerous. If we can get rid of smoking, I think the incidence of lung cancer will go down significantly.
And I feel like we've made a lot of progress to decrease traditional smoking, cigarettes and such. But are we still seeing this? How do you feel it's going to continue with the prevalence of vaping and things like that?
Vaping is equally dangerous, that's what I feel. Although the data is limited because it's a
Yeah.
recent trend, but it's equally harmful. So I don't think, if people think that somebody just thinks that I quit smoking and I'm starting vaping and I'm on a safer ground, I think that's a fallacy. That's not true.
Yeah.
Smoking of any form is injurious to the lungs, and it is going to cause an increased risk of lung cancer. So that is one big thing
Yeah.
in lifestyle modification that can reduce the incidence of lung cancer. And of course, then secondhand smoking, and then there are some occupational exposures like exposure to heavy metals, exposure to asbestos, people who work in shipyards, in construction, and wearing proper masks, protective equipment, protective gear, getting regular lung cancer screening done. If you fall in that category of high risk people, and maintaining a healthy lifestyle, eating a balanced diet, exercising, all the other stuff that applies to any other cancer
Right.
also applies to it.
Okay. I know people don't want to hear it about the stop smoking, but you're the second one to say it that I've heard today. So it does has a big impact on your body.
Yeah.
Okay, what about just from the outpatient pulmonology? I know you mentioned like asthma and stuff like that. Is there anything that can be done? I feel like around South Georgia, we have bad seasonal allergies, asthma
Right.
situation. What do you see?
A lot of
commonly
vegetation
around here?
and pollens and a lot of antigens in the air. Definitely, it leads to a trigger of seasonal, allergies. The people should seek medical help. They should use the inhalers that are prescribed on a regular basis. Avoid any triggers which can be different from person to person. Some people
Yeah.
are allergic to, say, cold. Some people may be allergic to dust. Some people may be allergic to smoke. So individual triggers are different. So they have to understand what triggers their asthma, and they have to make an effort to avoid those triggers.
Okay. And what exactly is asthma? I know this, what happens in your body when a trigger
Asthma is essentially
occurs?
an allergic response where the airways, they have an intense inflammatory reaction that leads to a constriction of the size of the airway,
Okay.
which leads to a decreased airflow. Because if the airway is this big, because of inflammation, there is a muscle spasm and it becomes smaller. So the air has less room to move. It makes it immensely difficult for people
Yeah.
to move air and to breathe. That is what asthma is. It's an
Okay.
allergic reaction, basically.
It's just interesting how all these different components can impact your body.
Yeah.
Just these external factors. Okay, well, let's talk a little bit about medical education, because I know you are involved in our internal medicine residency program here at SGMC Health. So tell us about medical education and, kind of your role and what you like about it, and if you could give any advice to any medical students.
I work as a core faculty in the South Georgia Medical Center IM residency program. And my role is to train the next generation of physicians. I train them to think rigorously and integrate physiology, pathophysiology, pharmacology, clinical assessment, and a bedside physical exam together to come up with a comprehensive diagnostic plan and to become physicians who are empathetic, who understand what the patient needs. My philosophy revolves around this. I think every patient has the diagnostic riddle of every patient. The key to that is held by the patient. So
Yeah.
bedside assessment is the key. And often the patient is willing to tell you what you need to know as a clinician, provided you are willing to listen. Data points like imaging, monitors, labs, they are just a supplement to bedside assessment. And they are not meant to replace it.
Right. Yeah.
They're not meant to replace it. They're only meant to supplement it.
So you're like an investigator,
Correct.
you know, when you're out on the field. Like,
Yeah. And another aspect is if you get lost in the maze and the web of numbers and data points, we often lose the touch or the sight of the human being that we are treating. As I said, standing at the bedside will give you more information than scanning through the chart, looking at all the numbers, looking at the monitor. But you need to do a physical exam. You need to understand the cultural aspect, the background, who the person was. When they are in ICU, they are intubated, they have a central line, they have monitors connected, they have all the web of wires and tubes and all. But eventually you should be able to see the human being that is lying there.
yeah.
What happened to them, why their physiology is deranged, why are they with you in the ICU? Obviously not a happy place.
Yeah.
And what you can do to get them out of the ICU. For that, you should be able to see through those lines and tubes and look at the human being and what is the derangement in the physiology.
I want to come shadow you for a day where I can watch your investigative skills in action.
Well, you're welcome.
But
Anytime.
that's so true, and I think that's why a lot of those Grey's Anatomy, all the medical shows that become very popular, because it is just like a problem that you're having to solve, and you're having to take so many different clues and put them
Correct.
together and find the answer. But
Critical care medicine, I say, is internal medicine at its best. It's medicine on steroids.
yeah,
You have a whole set of problems to deal with. It can be immensely challenging, but at the same time, it's immensely rewarding.
yeah.
When
I was
you-
going to
when you-
ask what your
when
most
you-
rewarding
when you-
part
when
of your
you-
job is.
Yeah, when you see people who come in struggling for their life,
Yeah.
you have a feeling sometimes that you nearly lost them.
Yeah.
And then you see them standing up, walking out, going to the floor. So the ability to do that, it's an art.
Yeah.
And I think a lot of it, as I said, comes from being comprehensive, being detailed. At the same time, you need to have quick thinking. You're making decisions in fractions of seconds.
Yeah.
So you have to have that mindset. And always, I encourage the residents and the medical students to read. Because your eyes can see only what your mind knows. So if you don't know,
Okay.
you will never be able to diagnose your patients.
Yeah.
And your patients have you. That's it. There's no one else.
That's right.
So I tell them, people say that, I want a doctor who I would want to care for my family if they fall sick. I tell them, I go a step further. I want a doctor who I think, to become a doctor, who I think I would want for myself
Yeah.
if I am in that position.
Yeah.
So that should be the philosophy. You should be able to think in that terms, that am I the person who I would want for myself if I was in this position?
Yeah.
So you have to kind of read, evolve.
How much time do you spend reading these days? You still hitting the books up?
I like reading. So yeah,
Yeah.
I think on an average, I almost read.
Because things are changing. I mean, things
Yeah.
are changing vastly. I mean, just think about all the advancements you already talked about just in the lung care. And
When I am not in ICU, I spend at least 2 to 3 hours reading every day.
wow.
At least 2, I would say.
Okay, well, if I'm ever in critical care, come check on me. I want you on my case. Okay. But we do appreciate you, and it is fascinating. I love this conversation. I've seen you in the hallways several times, but I did not know this side about you, and I love it because it is comforting knowing that we have physicians of your caliber and up there on the floors taking care of our patients. So.
I mean, it's a pleasure and an honor to serve the community here, to be a part of the community, to be a part of the medical staff here. And I think it's a privilege.
Well, thank you for that. And then last question is, this one, it should be, not as difficult as the others. But
You've asked me too many difficult questions for today.
what is your favorite thing to eat here at SGMC?
Salads. I'm a vegetarian.
Okay, salads.
So
The salad bar, you hit up that
it's
salad bar?
pretty impressive, and we
I
have
like
a
the
good
salad bar.
we have a good salads in the physician lounge also. So I think
All right, so you're speaking it and living it from the nutrition side.
yeah, but I need to exercise more probably.
It's hard. You can't, it's the ebb and flow. You can't do all of them perfectly all the time, right? You just baby steps. Keep it manageable. Otherwise, it's just too overwhelming, and you just say, I'm not doing any of it. So, well, we appreciate you so much for coming on today.
Of course, it was a pleasure.
And we'll link some information below regarding some of the things we talked about here in case you have any more questions or need contact information. And again, we just thank you, and thank you to our listeners for tuning in.
Thank you.